everyone. My name is Dr. Shavonda Jacobs-Young, and I'm the Undersecretary for Research, Education, and Economics at the U.S. Department of Agriculture and USDA's Chief Scientist. Today's panel brings together two of my favorite things, food and science. Food is an essential part of our lives. It brings us together as family and friends, and it's an essential part of the diverse cultures and who we are. Food is indeed the fabric of communities. That's why I'm honored to be moderating this panel session today. Today's panel is focused on what we can do to bolster and diversify nutrition science and our public health pipeline. Why doing so is critical to addressing long-standing barriers to food security, nutrition security, and health, and how we can fill gaps in data and develop more culturally responsive and effective public health programs. At USDA, we're bringing an equity lens to all of our research as we work to understand the connections between diet and cancer through the Cancer Moonshot and other initiatives to address food and nutrition insecurity. We're using precision nutrition to better understand the needs of underserved populations. And we're working to show how nutrition can be inclusive of all Americans. This includes demonstrating how culturally appropriate foods can be healthy. Today's conference creates an incredible opportunity to make meaningful and lasting change that will impact generations to come. Imagine a future where our nation is food secure and healthy. This is just the beginning. As we work together to tackle those challenges and move towards the future reimagined. I'm very excited for this fantastic panel today, so let's get started. But before we do, I want to remind those joining us virtually and those in the room with us here today to please submit your questions. They can be submitted either through the app or through the index cards listed on your, labeled on your chairs here today in the room. So each of our panelists today bring a unique perspective to this work. Could each of you introduce yourself and tell us why you believe it's so critical now to diversify the nutrition science and public health pipeline? And Jamika, why don't you go first?
Thank you so much. My name is Jamika Mills. I'm the co-founder of Equitable Spaces, where we focus on making sure that individuals with lived experiences of poverty are directly engaged in the design and discussion and creation of policies that are there to really help them, but really stand many times as barriers in our ways. So, grateful to be here. To me, I think that the critical connection is the reminder that when we're talking about data, we're talking about people, we're talking about lives, and the traumas that we have experienced through trying to navigate through these systems that were designed without us being at the forefront, without us giving our input. And so super grateful that we're having this conference and there is space and room for us to reimagine what this work can look like, but grateful to be here.
Thank you so much. Mia.
Hi, my name is Mia Ives-Rubley. I am the director of the Disability Justice Initiative at the Center for American Progress. I have been working at the Progressive think tank, utilizing a disability justice lens to better understand current policies and future hopeful policies that will come out. I'm super glad to be here today. I think that disability is often sort of ignored or invisible when we talk about a lot of different policies, including around hunger. And, disability, what we like to say is disability is a cause and a consequence to poverty. There's a direct correlation between poverty, food insecurity, and disability. Disabled people are 3 times more likely to be food insecure than others. But little research is actually out there studying these effects. Yet even at the federal level, we don't keep sufficient track of how many disabled people utilize nutrition programs due to utilizing overly strict definitions of disability. That means that our food programs are often inadequate in addressing the needs of disabled people, so I'm so glad to be able to talk about that today.
Thank you so much, Mia. Maribel.
So, good day. My name is Maribel Campos, and I'm a pediatrician neonatologist at the University of Puerto Rico. And COHIL was established by integrating the students that had come into our center seeking opportunities to get engaged in clinical research. And when we were hit by Maria, and before even Maria Irma, it was an opportunity for them to come with us into the community and learn about the real Puerto Rico, the Puerto Rico they wouldn't have met had they not gone out their academic institutions and actually interact with the people where they live and how they live. In supporting that level of understanding of individuals who are seeking to become part of the healthcare system, we have continued to work in collaboration with different members of that health system sector, including the Puerto Rico WIC program. And we're fortunate to receive funding from Robert Wood Johnson Foundation to assist them in their development of their educational platform in a way that was informed by Puerto Rico WIC participants, so that it was responsive to their needs in terms of the information included, but also in the way that it was presented. In that platform, it helped them sustain their connection with the community of service through Maria, and now to transition to remote delivery care during the pandemic. So that sustained collaboration has also helped them move forward, innovating in a way that they can also bring in other members of the healthcare system to support the community they serve. So those voices are extremely important and not as homogeneous as some would think they are, because if you give a plantain to a Puerto Rican, they will make mofongo. You give it to a Cuban, they will make patacon. You give it to a Dominican, they will make mango. And that nuance is important to be acknowledged and taken into account when we look at remote data.
Yes. Thank you. Thank you so much. Donald.
Well, thank you very much for having me be a part of this panel. My name is Donald Warren. I'm a family physician. I'm Oglala Lakota, originally from Kyle, South Dakota, on the Pine Ridge Indian Reservation. I also have training in public health. So I approach these issues from multiple perspectives: a cultural perspective, medical perspective, public health perspective, and also an academic perspective. I'm currently the co-director of the Center for Indigenous Health at Johns Hopkins University. Just took that job September 1st, so this is very new in this role at Johns Hopkins. But it's, thank you very much. These are vitally important issues to look at from diverse perspectives. And I've seen firsthand the outcomes of poor nutrition and nutrition-related diseases as a family doctor. But I also have seen circumstances where we hire new physicians in Indian Health Service or tribal programs, and they don't really understand the culture. And just as a very brief example, we had hired a new family doctor who was a vegan and came to the reservation community and was recommending that all her patients become vegan. But some of our ceremonies incorporate things like buffalo meat, and her response, well, we'll just change the ceremony. So just imagine physicians coming in and essentially telling people that they need to change their religious practices to be healthy, and that's just not acceptable. But it's not uncommon to hear these types of stories because of just the lack of understanding and the lack of diversity in the workforce.
Thank you for sharing that. Now I'd like to dive deeper into the longstanding barriers to food security, nutrition, security and health access for underserved populations. Jamika, could you tell us more about how your experience as a community college student and research assistant demonstrates the barriers many students face? And why do we need to include students and others who lived experiences in research and policy from the start to equitably address their needs?
Yes, absolutely. So, as a community college student, as many of you guys heard in the opening remarks, I struggled with housing and food and childcare, transportation, many of the things that today's college students struggle with. But when there's assumptions made about who students are or what students need in order to survive and thrive, we miss a mark and we create even more challenges for students. And so for me, the first time that my eyes were open to really the impact of having lived experience, but actually using that lived experience, leveraging that to create change was my school did a food pilot. And they petitioned these researchers, these amazing researchers, to do this food pilot at the school. We're going to give a certain amount of food to students biweekly. I was super excited to be, brought on as a student researcher and talking to my fellow students because I had that experience that they had. And so as the food pilot went on, students began to share the barriers to accessing the food. Some of them were homeless, literally didn't have a home to take the food to. Some of them did not have transportation to cart the food home. Houston is a huge city. And so hearing those things we set out to help. We set out to feed hungry students. But the mark was missed because we didn't start with talking directly to the students. What is the best food for you? What is the best way for us to give this food to you? Do you have a home to bring the food to? How do we store this? How do we support you? And so it was that experience really, opened my eyes to if that engagement started early and was intentional and purposeful, the research study, made plenty of people were fed. But I just think about all the many more who would have gotten access had we had that information at the onset. And so the culmination of that research, we presented on that in 2020, right before the pandemic hit. And so, I still, think about, what we could have done if, everything would, if the world wouldn't have shut down when it did. But just driving home the importance of if we are not engaging those who are directly impacted, it's almost impossible for us to solve for hunger, housing, childcare, whatever you're looking to solve for. You have to start with those who are the experts in that experience. And those experts are those who've experienced hunger, poverty, and other disparities.
Absolutely. And so thank you so much, Jamika. Mia, could you talk more about the food security, nutrition security, and health disparities facing individuals with disabilities? And how can policies and programs better address them?
Yeah, that's a heavy question. Like I said earlier, disabled people are 3 times more likely to be food insecure than non-disabled people, and it gets worse when you add in combinations of race and LGBTQ status. So we're looking at a very vulnerable population, individuals who become disabled because of food insecurity or are food insecure because they have a disability. So, a lot of them are definitely eligible for programs like SNAP, WIC, and other food programs, but those food programs aren't adequate for disabled people. There's a number of barriers that disabled people face when they are trying to access these services and access food in general. So some of these barriers include things like administrative barriers. So having to prove that they have a disability can be a significant barrier for them. They have to go to a doctor to explain how their disability impacts their ability to work and live in their community, et cetera, which costs money to go to a doctor. And so they often have to go through stringent requirements to prove that they have some type of disability and that they can't work. Individuals who are in rural areas oftentimes have difficulty getting transportation, accessible transportation to grocery stores. Many of them live in food deserts. So there's a wide variety of reasons why disabled people are still unable to access food, and we saw an increase in that during the pandemic. The Center for American Progress, we actually did a study on food insecurity of disabled people during the pandemic. We talked to programs like Centers for Independent Living, which are groups that help individuals with disabilities with being able to live in their communities. And what we looked at was that there was a couple of programs that were helping disabled people and helping reach out to them. And that included things like the CARES Act, which provided funding to the Administration for Community Living, or ACL. And this provided sort of a blank check to these CILs to get creative in their communities. And so certain CILs did that. They actually created their own food programs, their own food networks that worked with other community organizations and helped them be able to order food and deliver the food, because many of the individuals weren't able to actually go into grocery stores because they were at risk of high comorbidities around COVID. So, you know, there were other also programs that were expanded, including the pilot program for hot food. And that expanded it so that disabled people could get hot food, because many individuals live with kitchens that are inaccessible. I'm an individual that has an inaccessible kitchen. I can't cook in my kitchen because I just can't reach the counters very well. So it provides hot food. It also allows individuals to order food online. And I just want to really emphasize that nutrition is so complicated within the disability community, where you may think that one way of providing nutrition is acceptable for one community, but it's not for another community due to nutritional issues or cultural issues, et cetera. And so all of that needs to be taken into account when we're creating policies.
Absolutely. Thank you so much, Mia. I know we got in the practice of doing that during our prep session, but yes, that is just, thank you just so much, both of you. And so Donald and Maribel, I want to just provide you an opportunity if you want to talk a little bit about any of the long-standing barriers, if you had anything to add.
In terms of the barriers in the process of enacting any emergency response or even supporting to these communities, acknowledging the power and the assets of those that are already serving those communities. Who better is engaged with them, has their trust, and better placed to actually use any resources and spend the most of the resources for the purpose of why the fund is established in the first place. In that process, we saw moms that until our children had access to the pandemic committee to address having them at home, children who used to eat at the school, having moms that didn't have access to formula, and they had an adolescent at the same time, those of us who have adolescents at home know that they raid the fridge and everything else. It was impossible to sustain that without having resources at hand. So certainly those who are in the community are better positioned to invest the best way possible to address their community's needs.
Yeah, and I agree with that very much. And I think one of the other considerations is that we need to have a diverse workforce and a diverse research workforce in particular. And I think that a longstanding barrier for American Indian and Alaska Native populations is underrepresentation across the health field, whether it's as dietitians or physicians or researchers or really any health profession. So in my previous role at University of North Dakota, I was director of the Indians into Medicine, or InMed program, which is very successful in training American Indian physicians. But if we look at the broader data, we represent nearly 3% of the US population, but 0.5% of physicians. And it's similar disparities in other health professions. So we also started a PhD in Indigenous health, and it was the first one in the nation. And the focus is on ensuring that we're developing culturally relevant and culturally appropriate research and training our own people with lived experience to be the researchers. And the reason that's important, previously in another iteration of my career many years ago, I worked for NIH actually. So I was a staff clinician with National Institutes of Health, specifically NIDDK, National Institute of Diabetes, Digestive and Kidney Disorders. And they're doing a lot of research with American Indian populations and diabetes. And way back in 2000, so more than 20 years ago, there was a PBS documentary looking at obesity in the United States. And one of our researchers, who was very well trained in research, very, very good scientist, went on national TV and said that this particular tribe was exposed to the exact same diet as everyone else, but they have higher rates of diabetes, therefore it must be genetic. So that was the area of focus of research. So the next day I went into his office, and many of you might know about the Commodity Food Program or Food Distribution Program on Indian reservations. And I asked him, well, what about the Commodity Food Program? You know what he said? What's the Commodity Food Program? So if we don't have diversity in the research workforce, and if we don't have lived experience among the researchers, we're not even going to ask the right questions. So I think that it's wonderful that this is a pillar, but we have to ensure that we're investing in the right research workforce as well.
And so Donna, I want to stay with you for just a moment. You talked a little bit about this, but I'd like to turn to how we can address the gaps in data, and how that can help us develop more responsive programs and policies and improve health equity. So can you tell us about some strategies that have been effective in your experience working with the American Indian population?
Yeah, and it's a very complex issue, and it could be a week-long conference on its own, just looking at things like data sovereignty and looking at how we might better collect data and do it in a culturally relevant manner and scientifically sound manner. But in terms of successful projects, I have led several research projects and research centers in the Northern Great Plains. And our first step was to work with the tribal communities to identify what their research priorities are. So again, much like what has been stated already, if we're not engaging people who have that lived experience, we're not going to take the right steps. So in that process, just developing an inventory of tribal research agendas, for example, is very important. And not surprisingly, much of the priorities for research and programming includes things like inadequate nutrition and diet-related illnesses like diabetes, heart disease, and cancer. So those are some of the priorities that are generated from the communities. But also the role for academics then is to not just have the publication, right? We need to be actively involved in ensuring that the data are used for appropriate advocacy and actually making meaningful changes.
Yeah, absolutely. I think about the Extension Service in collaboration with the USDA and the land-grant universities, and how important it is to get that information disseminated and not in peer-review publication status, right?
Exactly.
But through some translation. Maribel, you've seen how place-based conditions impact nutrition. How have you worked to design programs to be responsive to these conditions?
So beyond the program that we used to leverage to help Puerto Rico WE program to develop the online education platform, we continued that collaboration, and as the pandemic affected and Maria affected not only the way that the program was functioning, but also the entire healthcare system because of the collapse of communication and all the infrastructure that was in place to provide that care. Pediatricians were displaced, so they had issues to be able to connect with them for forms that were required of the program for them to make adjustments in the services that their participants were providing. So we were that ally, which is an extremely important thing to be, not only to accompany our partners when they do have those advocacy efforts, and we play our role, not as the experts of what's happening, but rather to validate the implications in what is our asset as expert in X field, to have that point come across. And in that, we assisted participants to have access to where pediatricians who were actively providing care were. And also, we assisted them in the development of a better system where pediatricians could connect with the program using an online system so that they could comply with the regulations of having that documentation in place. We envisioned that that could be further assisted to actually develop a shared care model so that pediatricians continue to have a collaboration through that technological bridge. Because one of the elements that our participants had expressed to us is the fact that they have confusing messaging from the professionals at WIC and then from their pediatrician. How we then harmonize the information that they're getting, because at the end of the day, they end up being confused. Whose recommendations should they follow? And they follow anyone else, including the internet, and not necessarily the best information that they will use. We have also established a program that it falls under the STEM plus M category, where we are using, leveraging once more of the grit of our communities and parents who have shared with us where they trust us. It's not only the question you ask, it's also who's asking that question. And in that sense, you get a trustworthy and valid answer. And in sharing that information with us, we have built a STEM program in collaboration with Mayo Clinic, where we're implementing with Boys and Girls Club in Puerto Rico, where children learn about the effects of toxic stress on their body. They learn strategies to actually respond to the stress in more healthful ways. And our next curriculum will target whole body health and nutrition and physical activity being at the forefront of it. But they also learn about how to use science to make better decisions, using experimental models, teaching each other, and also providing them an opportunity to demonstrate that and teach one to someone else. You can see how when they're provided with fruits and vegetables, having gone through the program, they not only prefer to consume that, but they ensure that their mom has an opportunity to consume that as well. So it's building that pipeline.
Absolutely. Thank you both so much. And so, Mia and Jamika, I want to give you an opportunity if you would like to address the questions of how do we address gaps in data and develop more culturally responsive programs and policies from your experiences.
Yeah, I mean, for me, and I love what you shared, Donald. You know, just think about like when we engage folks, and as you mentioned too, Dr. What are the questions that we're asking? Who's asking those questions? Who is developing these questions? And you know, part of the experience that I had was when we tried to send out information to the students about the research that we were doing, we had to rewrite that email. We had to change what was in that subject line. But the researchers they had to be informed by someone who had that lived experience to say, hey, if I got this email, I would send it to the trash because it is not highlighting what is important to me. I do not, you know, it doesn't make sense to me. It's not reflective of my experience. But when we truly engage folks that have those experiences, then we're able to tell you, this is how you should ask that question. This is how you should, you know, develop this line of questioning so that we see ourselves reflected and that we're able to give the pure and authentic feedback that we all need. But imagine if you have someone who has that direct experience, not only helping to craft those questions, to, you know, develop that, but then going out into community and actually speaking to them. So to piggyback off what Donald said, let's get a more diverse group of researchers and folks in data that look like us, that have the experiences that we've all experienced, and I think that the information will be that much more richer.
Okay, I'm going to give you one of these. Fantastic. I love that. Mia.
Yeah, I think that one of the things that we've seen in the disability community is sort of a renaissance of sort of new disability leaders who have been coming from more diverse backgrounds, which has been extremely important because disability is not experienced in the same way in different communities. Each community has its own perspectives on disability. It has its own set of barriers that they face within specific communities. So, you know, it's been very, very important to include a lot of these voices. And so often people are like, oh, these are the voiceless, right? Like, I hate that term because I'm like, nobody is actually voiceless. Like, everybody has a voice. It's just you're not listening to these communities, right?
Yeah.
So I think it's extremely important that one, as everybody basically has said, create a pipeline of researchers who come from those communities to be able to do the outreach that is needed to better understand the community. I think also being able to disaggregate more data. That's a huge term within the API community, but it's also important in other communities as well, to better understand the uniqueness of every community, because no community is a monolith, right? And then lastly, I think we discount qualitative data so much. You know, we spend so much time saying, well, we need quantitative data. We need those hard numbers to be able to make decisions on policy. But people aren't numbers, like you said, right? People are complex human beings that have their own stories, that have their own perspectives. And so if we don't allow us to utilize more qualitative data, we miss a portion of the whole picture. And so one of the things that I love to do through my team is to utilize a lot of qualitative data to back up some of the quantitative data so we can better understand the full picture of what's going on in each community.
Absolutely. So in our last 5 minutes, I know it's hard to believe. You know, this morning, a couple of people gave us homework assignments, you know, and it's because if we just have this conference and we all go back home and just say, oh, that was a wonderful conference, you know, so succinctly, if you wanted to share at least one thing, the most important thing at this moment for these folks to take away and the folks that are watching us virtually, what would you want them to take away from this conversation and from this summit today? Donald, I'll start with you.
Very difficult to kind of narrow that down, but I think a couple things. One, I think that we do need to understand the disparities and the challenges that we're facing with health inequities, but our communities also have a lot of strengths, and there's a lot of strength and value in culture. So I don't think we should just be looking at studying the negative impact of bad food. Let's study the positive impact of traditional food. You know, let's look at it from a strengths base and resilience base as well.
Absolutely. Thank you, Donald. Maribel.
In that sense, and I totally agree with what just said, is also filling the gap of elements that for many of us continue to be an asterisk, because in certain territories we don't have surveillance systems that collect real-time data in a concurrent way. So what other assets could be leveraged that would then bring in the information of how the current status is and what are the saliency elements that would allow us to then target as a part of an intervention.
Absolutely. Thank you, Maribel. Mia.
I think that, one, to understand that work does not equal worth, and everybody everywhere deserves access to food, deserve access to a lot of different resources. But two, also making a commitment, yourself making a commitment to helping amplify voices that aren't often heard, that aren't often on these stages, to ensure that they don't remain voiceless, right? That you're amplifying their voices and their experiences and making sure that they're heard within all different fields.
Jamika.
And yes, I'm gonna die on this hill, y'all. We are the data. These are people's lives. These are people's experiences, their traumas. We cannot separate the two and make it, numbers or people. We are the data. And so if there's anything that, I hope going forward is that, that doesn't have to be a reminder anymore, that folks aren't able to separate or compartmentalize for themselves when we're talking about these disparities in actual lives. So I just want everyone, when we walk away from here today, to let's think about when we're talking about data and research and really remember that we're talking about individuals, we're talking about human beings. And so, in the solutions lie within those same, humans that we are, considering as data. So lean into your experts in your communities, in our nation. And if we do it the right way, we won't have to do this again. We won't have to have this in 60 years. So.
Well, I want to thank all of our panelists today. Thank you for your time, for your talent and your perspectives. And I want to thank the audience for joining us today. I know there are a lot of competing activities, but you were here with us, and we appreciate that, those here in the room and those virtually. So just thank you all, and that concludes our panel. So thank you so much.